So I will take advantage of this time just to say hello to everybody that is connected, to thank you for the invitation. I'm very honored and privileged to be here today and to comment on Wei-Peng. Please, Carissa, can I share my slides? Okay, I think it's okay.
Yeah, are you able to share?
Okay. So do you see it? Please confirm.
Yes, it's correct. We see your slide.
So I have nothing to disclose except for the fact that I'm a surgeon. So it's usually medical oncologists challenging the surgeons on their IP cooking protocols, not the other way around. I will try to start by summarizing what I understood from Wei-Peng's presentation. So where are we now for metastatic gastric cancer treated with chemo or immunotherapy? I would need to say that the best outcomes we recorded so far are already far away from the trial that is made in resectable gastric cancer that has 50 months of overall survival. Because in metastatic gastric cancer that is HER2 negative, we only are in the first line at our best results of 17 months. It's a little bit incorrect because this is indirect comparison. So this is not directly comparative studies, but we've seen 17 months with the Attraction 4 trial and with the Keynote 062 trial in the subset of patients that are that have CPS more than 10. In the second line with the Rainbow trial that has been published a few years ago, our best results are an overall survival of about 10 months. But when we go to the third line, our results go down by half, and we only have 5 to 6 months, either with oral chemotherapy or with nivolumab immunotherapy. But where are we now for metastatic gastric cancer treated with maybe combined strategies and other than systemic chemo or immunotherapy? As you've already seen in Wei-Peng's presentation, some data from the Phoenix trial that Hironori will probably present us much more in depth. In the IP arm of this study, we have an overall survival of 17.7 months when we combine IP paclitaxel with systemic chemo. When we take a look at the now almost historical trial, Regatta, that combined gastrectomy followed by systemic chemotherapy with systemic chemotherapy alone, and there was no significant difference, we can see that the overall survival for both arms was about 16.6 months. When we go to the most recent retrospective but propensity score based study that compares cytoreductive surgery plus HIPEC with cytoreductive surgery alone following systemic chemotherapy, we can see that overall survival goes up to 18.8 months for the HIPEC group. And when we took a look at more recently published studies that combine systemic chemotherapy with PIPAC, not necessarily in the first line of treatment, only 50% of the patients are in the first line in the Lyon cohort, we can see that overall survival goes to 19 months. So I think that after taking a look at all those results, we can actually conclude that in the first line of treatment, there is some sort of glass ceiling that does not allow us to pass the 17 to 19 months. So the question would be, how do we get past that ceiling? And combining strategies, even more strategies, seems to work. If we take a look at some subgroup of patients in the Phoenix trial, we can see that those patients that responded well to the IP arm and that benefited from gastrectomy have a survival so high as 32 months, which is actually the equivalent of the survival in the MAGIC trial or in the control arm for the FLOT trial. Further studies will bring even more answers on that. We have the Renaissance trial on Europe with gastrectomy following with the FLOT regimen. But is it also enough to assemble together all these pieces, all these different strategies into one? Probably not, because in gastric cancer and in other types of digestive cancer as well, we have a lot of factors to juggle. We have the Asian versus Western populations differences, and they have been well looked upon. We have 4 molecular subtypes in 2 almost different classifications. I only put one of the classification, the one from the Genome Project, but the other one is quite similar, but also takes into account P53 and EMT. And these types of molecular classifications impact the response to chemotherapy, for instance. We have classic factors such as tumor location and lymph node involvement. We have signet rings of cells. We have positive cytology versus peritoneal mets. And we do have also other novel targets, potential targets such as claudin or metalloprotease. So it's probably not enough just to assemble all these strategies into one, but just rather put different puzzle pieces into different puzzles for each of these subcategories. In the second line, I will be very short. Survival is less than 1 year. So we probably need to select the respondents and probably treat with priority those people that are respondents, explore the use of less toxic chemotherapies such as IP, PIPEC, and LAP-HIPEC. And keep in mind that patients with ECOG more than 2 are mostly absent from the trials done in more than second-line setting. Also, probably quality of life and patient-reported outcomes are currently insufficiently explored, and they are very important to take into account for patients that are supposed to live less than a year. So my key point is that it's probably not a mutual challenge between the medical oncologist and the surgical oncologist, but a mutual collaboration. And I'm really looking forward to learn more in-depth data from the following speakers about each one of these strategies. Thank you.
Thank you. Thank you, Olivia. Okay, Mark, you want to move on to the next speaker?
Yes, I think we have to come on to the next speaker. We will speak about intraperitoneal chemotherapy, and we will go to Japan for that with one of the best TSSPP members from Japan. And thank you to be with us, because I think it's very late in Japan, and the pictures behind you is not the reality. I think it's completely dark now. So Hironori Ishigami is one of the best surgeons in the world from gastric cancer. Yeah. So we'll be happy to have your input regarding all that question. Thank you. Thank you to be with us.